as a consultant in Sindhura Hospitals, Hyderabad. And Dr. Sindhura is a very good, experienced emergency physician, and she's very academically oriented. I really thank her for accepting my invitation and presenting this lecture today. Thank you, Dr. Sindhu. Please, you can go ahead now.
Good evening, everybody. It's nice to have you all on board on today's class. So, chemical burns are a distinct and potentially devastating form of tissue injury resulting from exposure to corrosive substances. So, these are very rare actually, and let us just get to see how do we have to manage them in the emergency. So we will be taking you through introduction, the scope and relevance of chemical burns in emergency department, its epidemiology, pathophysiology, initial assessment, treatment, and the systemic effects associated with chemical burns. And a special note on ocular chemical injury also will be dealt with, and common mistakes to avoid while treating chemical injuries. And we have few case studies which we can discuss. And there are some notable industrial gas leak and chemical burn case studies that we will discuss and make it interesting for today. So coming to the introduction, chemical burns are those which are caused due to exposure to corrosive substances. And these burns are injuries to the skin, eyes, or internal organs which are caused due to corrosive substances basically. So what is really important here in case of chemical injuries in our emergency department is the rapid identification and early intervention. So scope and relevance of chemical injuries in the emergency department is that these injuries are very uncommon but potentially severe. And severity depends on the agent, concentration, duration of contact, and penetration depth. And these are usually seen in industrial accidents, household exposures, and in case of assaults these days. And these require rapid decontamination and stabilization. I would want to emphasize on this point that these injuries are uncommon. But just when I was preparing this PPT, there came a breaking news in the television that there was a chemical reactor blast that happened in an industry which is in the outskirts of Hyderabad. It is Pasha Mailaram Industrial Estate, which falls in the outskirts of Hyderabad, which happened just on June 30th, 2025 at 9 a.m. And it is the Sigachi Industries company, which is basically a manufacturer of microcrystalline cellulose and excipients. The casualties that were seen here were 34 to 40 plus deaths and 33 plus were injured, and many critically with burns and inhalational injuries. So the nature of explosion here was possibly due to thermal chemical reaction in a spray drying unit, and the blast triggered a fire that engulfed most of the building. And chemicals involved likely included organic solvents, cellulose dust, and acid or base catalysts. So now we cannot say that disasters are uncommon anymore. Disasters have become very common, and as a part of it, chemical injuries also are being very commonly encountered these days. So let us see how chemical burns are different from the usual burns. So coming to the cause of chemical burns, it is nothing but due to the contact with corrosive chemicals like acids, alkalis, oxidants, and solvents. And here the tissue damage is really important because it is caused by chemical reactions, and that chemical reactions are protein denaturation and fat saponification as in case of alkalis, and coagulation necrosis as in case of acids. Chemical injuries may look mild, deceptively mild, but behave severely due to their delayed progression, deep tissue injury, and systemic toxicity. And this injury may continue as long as the chemical remains in contact. So immediate and aggressive irrigation is life as well as tissue saving in case of chemical burns. So coming to the epidemiology, the common agents that we encounter are in the category of alkalis. They are the cleaning agents like sodium hydroxide and fireworks that we commonly see, and kitchen burns also are due to the alkalis that are used. And acids are encountered in battery acid, toilet cleaners, etc. And other substances like hydrofluoric acid, phenol, anhydrous ammonia are a few important ones that we encounter commonly. And the settings, this can happen either in industrial sites, agriculture, or household accidents. So coming to the pathophysiology of chemical burns, to keep it very simple, alkalis cause liquefactive necrosis, which result in deep tissue penetration, whereas acids cause coagulative necrosis, leading to eschar formation. So comparatively, alkalis penetrate more deeper and cause more deeper tissue injury than what acids can cause. Because in case of acids, there is an eschar formation which will further prevent further penetration of the chemical. So systemic absorption can lead to metabolic disturbances, and special concern are those like hydrofluoric acid, wherein we see hypocalcemia, arrhythmias, and many such complications. Let's see more in detail about those things later. So coming to the initial assessment, first and foremost thing that we have to do to a patient who's gotten a chemical burn is to remove the patient from the source of exposure. And the next thing is we'll have to decontaminate before even full assessment. But while decontaminating, simultaneously ABCs should be assessed. And once that is done, immediate and copious irrigation should be started off, and identification of chemical agent if possible should be done, because there are few chemical agents in which copious irrigation is not indicated. We'll get into all those details later on. So the management of chemical burns, I'll be dealing in with four steps. So the first and foremost is to ensure scene safety, that is usage of PPE, and the second step is decontamination, and third is hydrotherapy, that is irrigation of water for at least 20 to 30 minutes, and the fourth is usage of any specific antidotes when indicated, like calcium gluconate for hydrofluoric acid. So the first step is the scene safety and PPE usage. Scene safety involves containing the substance, extinguishing fires, and controlling other environmental hazards. And the first responders should always wear a PPE if available, but in case it's not, the bare minimum that we should have is a chemical resistant clothing with a hood, boots, eyewear, at least 2 layers of gloves, and some form of respiratory protection. So coming to the next step of decontamination usually starts with removing the patient's contaminated clothes. In case of dry chemicals, these chemicals should be brushed off even before copious irrigation with water is started. And in case of liquid chemicals, we can directly start off irrigating. So this contaminated water should and must be contained. And if decontamination is not performed on scene, it should be done even before the patient enters ED. And the primary and secondary survey can occur simultaneously with decontamination. Once decontamination is done, the next most important thing that we'll have to do is hydrotherapy. So how much of water is adequate? In a lot of books, we've just seen that it is given as large volume waters, but there are few studies which have come up recently in which they say it is 2 to 3 liters of water that is to be done ideally. And at what pressure? High pressure hydrotherapy is usually controversial because high pressure irrigation usually leads to spillage of the chemical, and even the rescuer is affected in such cases. So gentle pressure hydrotherapy is what is advocated. And for how long? Usually the bare minimum that we have to do is 20 to 30 minutes, but there are studies which say the longer you do, the better the outcome is. So 60 minutes have shown better outcome and 90 minutes even better, but it all depends on the number of casualties that we have in our ER, and the amount of chemical injuries that each one of them have got. But 20 to 30 minutes of hydrotherapy is the bare minimum that we should think of. And neutralization of the chemicals is not at all a good idea. There are many studies which say it's better we do not consider neutralization. And there are some contraindications to hydrotherapy as well. Not all agents are best decontaminated with hydrotherapy. In case of lye, it should be brushed away even before hydrotherapy is instituted. And in case of elemental metals like sodium or potassium, it may cause exothermic reaction when combined with water. So mineral oil is applied first to the skin. And then in case of phenol, it should not be irrigated with water owing to concern for enhanced skin penetration after exposure to water. But hydrotherapy should not be delayed while waiting for special agents like this, because hydrotherapy will definitely have some amount of benefit if we can't get those special agents that we have to use in those special situations. So next, when we look into the select chemical burns, so in the category of acids, generally all acids need prompt decontamination, copious irrigation with water. Acetic acid is usually used in our hair wave neutralizers, and this particularly leads to scald chemical burns. So in them, copious irrigation should be done immediately. And next is we'll have to consider systemic antibiotics for scalp burns. And in case of phenol, phenol is usually used in the chemical peels that the dermatologists advocate so as to reduce wrinkles and all these days. And that is the common area where we see chemical burns secondary to phenol usage. So in this also, there should be copious irrigation that should be done. But the antidote here is polyethylene glycol with 200 to 400 molecular weight Daltons. The peg that we use in colonoscopy is different from this. Here, the molecular weight is 200 to 400. So this is the antidote that should be used. But if that is not available, even isopropyl alcohol may be used. And in case of chromic acid, there is copious irrigation that is advocated, but only thing that is more concerning here is the systemic toxicity that is associated with chromic acid. And in case of formic acid, again, copious irrigation is the key, and dialysis may be needed in severe cases because nephrotoxicity is very much commonly encountered with formic acid toxicity. And in case of hydrofluoric acid acts differently because in this, the hydrogen ion and fluoride ions disintegrate, and the fluoride ion goes and binds the calcium and magnesium, which will further lead to the alteration of sodium potassium ATPase, and this results in hypocalcemia, hypomagnesemia, and hyperkalemia. So the systemic toxicity will be seen in hydrofluoric acid burns. Here, copious irrigation is the key, and 10% calcium gluconate intradermal should be considered for severe cases. But there is an alternative topical calcium gluconate, which is available as 2.5% gel for mild cases. And the main thing that we'll have to do here is to monitor calcium, magnesium, and ECG continuously, and also consider intraarterial calcium gluconate for severe cases. And 25 ml of 10% calcium gluconate in 75 ml water soluble lubricant is yet another topical form of giving calcium gluconate in case of hydrofluoric acid burns. And coming to the nitric acid chemical burns, copious irrigation is the key, and consulting burn specialist at an earlier stage is what has to be done here. And that is because it causes deeper penetration, and especially in case of finger burns and all, the excision of nails is what is followed by plastic surgeons in nitric oxide and nitric acid burns. And in case of oxalic acid, copious irrigation is the key, and IV calcium if needed. And here also we need to monitor electrolytes and renal function, also ECG. So coming to alkalis, in general, all alkalis need prompt decontamination. But in case of Portland cement, they need prolonged irrigation. That is because they remained in contact with the skin, they keep on penetrating deep into the skin and produce symptoms much later than what is at the onset of the burn. So prolonged irrigation should be advocated in case of Portland cement chemical burns, and these need scrubbing with brush to remove particles. And in case of elemental metals, like in case of sodium, lithium, potassium, magnesium, aluminium, and calcium, water should be avoided. And these fragments should be covered with sand, foam, Class D extinguisher, or mineral oil. And these fragments should be excised when they cannot be wiped off. So coming to the category of hydrocarbons, in case of gasoline, decontamination is the key, and in case of tar, cooling before removal should be done, and usage of antibiotic ointment with polysorbate is also important, and baby oil can also help in such cases. And the next category is the vesicants, where in case of mustards, decontamination and copious irrigation should be done. And if water is limited, use flour, talcum powder, fuller's earth, and then wipe off. And next category is the reducing agents, where alkyl mercury compounds are responsible for chemical burns. And in them, copious irrigation, debridement, and draining of blisters is done, because the blister fluid has high mercury content. And next is the category of lacrimators, where tear gas and pepper spray are the ones that we usually encounter. Even in these cases, copious irrigation should be done, and these lacrimators usually are associated with respiratory symptoms. Coming to the miscellaneous category, white phosphorus needs removal of clothing, copious irrigation, and if possible, the skin has to be kept wet or submerged. And the systemic toxicity risk is really high with white phosphorus. So debride visible particles. And in case of airbag chemical burns, the only thing that we can do is prolonged irrigation. So these are the systemic effects usually associated with chemical burns. Hydrofluoric acid, like we discussed, the systemic toxicity that is seen as hypocalcemia, hypomagnesemia, hyperkalemia, cardiac arrhythmias, and sudden death. And in case of tannic acid, chromic acid, formic acid, white phosphorus, there is nephrotoxicity as well as hepatic necrosis. And in case of cresol, methemoglobinemia is usually encountered. And in case of gasoline, severe pulmonary, cardiovascular, neurologic, renal, and hepatic complications are seen. And in case of phenol, usually cardiovascular and CNS toxicity is seen. And in case of sodium nitrate and potassium nitrate, again, severe methemoglobinemia with refractory cyanosis is seen. And in case of dichromate solution, liver failure, acute renal failure, and death despite dialysis is what is encountered. So having spoken about the systemic toxicity, let us just see the ocular chemical injuries, because this is one of the true ophthalmic emergencies. And in India, it is common due to firecracker injuries, lime, or accidental injury with holy colors. Copious irrigation should begin at the scene of the accident. And the targets of eye irrigation is usually 90 minutes of external irrigation or 1.5 unit reduction of the elevated pH. Litmus paper is usually used to check the pH of the cornea, and based on that, the irrigation should go on for as long as there is reduction in 1.5 units. So there is this classification of chemical eye injury, Ropel Hall classification, wherein it is divided into 4 grades based on corneal and limbal ischemia, corneal involvement and limbal ischemia. And prognosis is usually good in 1 and 2 grades, but it is very poor in 4th grade. So this is the pathophysiology of ocular chemical burn. The necrosis of the conjunctival and corneal epithelium happens, leading to disruption and occlusion of the limbal vasculature, thus resulting in loss of limbal stem cells, which further leads to conjunctivalization and vascularization of the corneal surface. And this results in persistent corneal epithelial defects with sterile corneal ulceration. So the first and foremost thing that we have to do in ER is irrigation of the eye, which should be done from the inner canthus to the outer canthus. And once that is done, the medical management should be followed in these steps. So copious irrigation is the first step, and then remove chemical completely from the conjunctival surface, cornea, and fornices. And then topical steroids are given, followed by topical citrate, topical ascorbate, and then tablet doxycycline is usually given for 2 weeks, and moxycycline eye drops QID, And other symptomatic management should be done. And surgical therapy like debridement, amniotic membrane transplantation, and tissue adhesives and tectonic keratoplasty are advocated in chemical ocular injuries. And that is the reason why early ophthalmic referral should be considered in such cases. So the common mistakes that we have to avoid while treating chemical burns is to avoid delay of irrigation, and neutralizing chemicals without expert advice is yet another mistake, and using inadequate volume of water, not protecting oneself, reaching the scene and treating the patients without PPE is a common mistake, and missing systemic toxicity signs is yet another mistake that we usually do. So now let us just see a few cases of chemical burns. It is the first case. It is a sulfuric acid burn, which is an industrial accident. He was a 35-year-old male who was worker at a battery manufacturing plant who accidentally spilled sulfuric acid on his forearm. And the symptoms that he came to the ED were with immediate burning sensation, blistering, and skin discoloration, and this pain worsened with time. So, coming to the treatment that we did, immediate irrigation with water was done for 30 minutes, and application of sterile dressing and pain management was taken care of, and skin grafting required after necrotic tissue debridement. So the outcome, looking to the outcome, he had partial loss of sensation in affected area, and there was full recovery over 4 months with physical therapy. So the learning point here is immediate and continuous irrigation is critical, and delay increases the depth of the burn. So the next case is the hydrofluoric acid burn, which was in a laboratory exposure. A 26-year-old chemistry student accidentally spilled hydrofluoric acid on hand while conducting an experiment. The symptoms that she came with were initially she had mild irritation, subsequently developed severe pain over the next 2 to 3 hours, and there were signs of tissue necrosis on arrival to ER. ECG showed early signs of cardiac arrhythmia due to calcium binding, like we discussed previously. And the treatment that we gave was copious irrigation with water, application of calcium gluconate gel, and monitoring and correction of electrolyte imbalances. Outcome, the patient's pain subsided after 2 days, and there was full recovery with no lasting tissue damage. The learning point here is hydrofluoric acid is uniquely dangerous because it penetrates deeply and binds calcium, potentially causing hypocalcemia and cardiac arrest sometimes. Coming to the third case, which is a household chemical burn, which happened due to sodium hypochlorite, which is nothing but our bleach. A 4-year-old child accidentally spilled bleach on the thigh while playing in a cleaning cabinet. And the symptoms that brought the child to the ER were redness, blistering, and crying due to pain. And the child also had vomiting and breathing difficulty due to inhalation of fumes. So the treatment included rinsing with lukewarm water and then admission for observation, and oxygen and bronchodilators were given for respiratory symptoms. Outcome was really good. The child had full recovery. Parents received child safety education. So the learning point here is household chemicals are a major source of burns in children, and prevention through storage safety is essential. And the next case that we saw was alkaline burn from cement. A 45-year-old construction worker had knee exposure to wet cement for several hours during work. Initially had no symptoms. Skin irritation was the only thing that he had, and that turned into deep ulceration within no time. And pain was delayed initially, and burn worsened over 24 to 48 hours. So the treatment here included the mechanical removal of residual cement, wound debridement and dressing changes, and antibiotics for secondary infection. So the outcome was that skin grafting was required in this case, and moderate scarring with some loss of mobility was there. But the learning point here is alkali burns are often deceptively painless at first, but penetrate deeper than acid burns. So delayed presentation is common in alkali burns. So having spoken about case studies, now let us see some notable industrial gas leak incidents which which had a lot of chemical burns as casualties. So, Bhopal gas tragedy, which happened in India in the year 1984, in December 3rd, 1984. The agent here was methyl isocyanate, and it happened in the setting of Union Carbide pesticide plant leak. And the exposures were mainly inhalational and some direct dermal exposure. There were 3,000 plus immediate deaths in casualties, and over 5 lakh were exposed. And the long term effects that were seen secondary to this gas tragedy were lung fibrosis, corneal opacities, and birth defects. So, what is relevant to us in emergency is that there were no decontamination protocols in place when this had happened, and lack of PPE and evacuation planning also was there. And this is an example of both inhalational and chemical burn injuries, and this emphasizes the importance of industrial disaster preparedness. And another such incident is the Gumi chemical leak, which happened in South Korea in the year 2012. It happened due to the agent hydrofluoric acid. It happened when a truck carrying hydrofluoric acid overturned near an industrial complex. And the exposures that were seen here were inhalational and skin contact with vapor. The casualties were around 5 deaths, and 3,000 people were treated for exposure symptoms. And vegetation and environment were extensively damaged in this particular accident. And the clinical relevance is that hydrofluoric acid causes deep tissue burns and systemic toxicity like hypocalcemia, cardiac arrhythmias, and any delay in identification worsens outcomes. So this case illustrates need for calcium gluconate as antidote and rapid triage or decontamination. Coming to the next case of West fertilizer plant explosion, which happened in USA in the year 2013. The agent involved here was ammonium nitrate explosion, and it happened in the setting of fertilizer plant in Texas. And the exposures were blast injuries with thermal and chemical burns. Casualties were around 15 deaths, including the 10 first responders, and 160 plus were injured, and extensive community damage also was observed as a part of this. And lessons for ED is that mass casualty triage under chaotic conditions was observed during this explosion, and mixed injury burns, basically burns caused due to thermal and chemical pathophysiology, and blast trauma, respiratory irritation, all of that were seen in this event. And coordination between EMS, ED, and hazardous materials teams is very vital. So coming to the next case, that is the Richmond refinery fire, which happened in USA in the year 2012 again. This happened due to the agent sulfuric acid vapor with hydrocarbons. And it happened in a setting of Chevron oil refinery. And the exposures were basically inhalation of irritant gases, and casualties around 15,000 plus sought medical attention, mostly for minor respiratory symptoms. But the relevance in ED is that this particular refinery fire showed overwhelmed local healthcare systems, and this highlighted the importance of community warning symptoms and proper PPE. And this is useful for simulating ED surge capacity planning. And one more is the Visakhapatnam polymer gas leak, which happened in India, in Andhra Pradesh in the year 2020. The agent involved here was styrene gas, and it happened in the setting of a chemical plant storing polymer materials. And exposures here were basically inhalational, and styrene gas usually causes ataxia, seizures, more of neurological symptoms. So there were around 11 deaths and hundreds were hospitalized. And the key points for ED is that styrene is an irritant and neurotoxin, presence with mucosal irritation, ataxia, and seizures. So evacuation, decontamination, and rapid airway management are crucial in such cases. So having said about the notable gas leak incidents, let us just throw some light on what is chemical terrorism. So chemical terrorism is usually the deliberate release of toxic chemicals to harm or kill people, and it is motivated by ideological, political, or religious goals. And there are serious implications for public health and emergency preparedness. And first responders also turn symptomatic in this case. This is something that is very important and will have to be really prepared and ready to tackle that case. So there are some historical examples of chemical terrorism which happened in Tokyo subway attack. The agent used was sarin in the year 1995, and Halabja massacre, which happened with the mustard and nerve agents, and that was in 1988 in Iraq. And ISIS attacks, which used chlorine and mustard, and that again was in 2014 to 2017. So the commonly used agents for chemical terrorism are nerve agents, blister agents, blood agents, choking agents, and irritants. So nerve agents include sarin, sabin, and all, which almost the mechanism of action of them is acetylcholinesterase inhibition. They come to us with sludge symptoms. And in case of blister agents like sulfur, mustard, levisite, the mechanism of action is alkylation, and the clinical effects that people come to us with are skin, eye, and lung damage. And in blood agents like hydrogen cyanide, cellular respiration inhibition is the mechanism of action, and clinical effects range from hypoxia to seizures. And in case of choking agents like chlorine and phosgene, pulmonary edema is the mechanism of action, and clinical effects that we see are dyspnea and ARDS. And in case of irritants like CSC and gas, there is sensory irritation that is seen, and people come to us with lacrimation, cough, SOB, and such symptoms. So this was about chemical burns, some notable chemical gas leak accidents, and chemical terrorism. So I think coming to the take-home points, immediate decontamination is critical. Begin copious irrigation with water unless contraindicated. And second is know the chemical. Tailor management based on the specific agent, like in cases of hydrofluoric acid and alkali metals. And number three, do not neutralize chemicals on skin because that can cause exothermic reactions and worsen injury. And number four is hydrofluoric acid is highly dangerous. Risk of life-threatening hypocalcemia and arrhythmias are seen. So use calcium gluconate as early as possible. And in case of alkali burns, always remember alkali burns are more severe than acid burns, and deeper tissue penetration due to liquefactive necrosis is seen in such cases. And in case of elemental metals, they require special handling, and that is they do not we should not be using water for irrigating them because that can cause combustion. So removal of such metals is the key, and usage of mineral oil and all can be done additionally. And then the next point is always assess for systemic toxicity, especially in white phosphorus, hydrofluoric acid, or phenol exposure, and involve toxicology or burn specialists early, especially in inhalational injuries, large surface burns, or uncertain agents. And document everything: time of exposure, agent, irrigation, duration, and systemic symptoms. And prevention and PPE are essential in industrial settings and pre-hospital as well. So this was about chemical burns. So we are open for questions now.
Yeah, thank you, Dr. Sindhu, for a very good session. I think there's a question in the chat box. So, how to use intra-arterial calcium and any complications associated?
Actually, there are very less studies which have shown the usage of intra-arterial calcium gluconate. We'll have to take it in 50 ml solution. So calcium gluconate 10 ml should be dissolved in 40 ml of DNS, and that should be infused over 4 hours intra-arterially. There are only two studies as per what my knowledge goes, and there were not many complications. It's actually the risk is to benefit ratio. So, but many of the other severe cases of hydrofluoric acid also have only used IV over intraarterial, but intraarterial is definitely showing better results than this. We need more studies to understand if there are any side effects.
Yeah, so basically the use of that would be to chelate the free fluoride ions so that they don't go and penetrate further and damage it. And they are chelated and it forms calcium fluoride, which is insoluble in the blood. I'm sorry, the tissue. So that's why that is the major thing. And also because this is going to chelate the existing body calcium ions. So it will cause hypocalcemia and arrhythmias and further. So that to prevent that, we can give the calcium supplementation. That is the major pathophysiology behind this drug. So there's another question which says that what about the management of ingested chemical agents? So you want to take that question, ma'am?
Yeah, coming when ingested chemical agents.
Yeah. So in the
So
ingested
ingested chemical agents usually come with the systemic toxicity. In them, we can't irrigate anything, but the mucosal irrigation is yet again something that we can advocate based on the severity, based on the case basis. So, but it's more of systemic toxicity that we see in such cases.
Yeah, they wanted to ask about sulfuric acid and also the corrosives. All of these should not be gastric lavage should not be done, obviously.
Yeah.
And there's another specific thing which is the white phosphorus, which also called as the aluminium phosphate. So this one will form the phosphine gas when it comes in contact with the stomach water or any water. If you irrigate also, it will come into it forms a phosphine gas. So there is a exemption for this where you can use coconut oil or you can use potassium permanganate mixed with coconut oil or glycerol also can be used for this specific thing. But otherwise, don't use uh, any kind of lavage for these corrosives. And usually we avoid lavage in hydrocarbons also because they might cause aspiration pneumonitis. But you have to go with the risk versus benefit. So you want to add something to that?
Yeah, yeah. That's what it is.
So I think that's about it. We have also reached 40 minutes mark, and so we'll conclude today's session. And next week we have review of ECPR by Dr. Subankar Paul. And this is a very interesting session where we'll see how to do the ECPR or ECMO CPR in emergency medicine and what are the indications and contraindications for all of these. The use of it is increasing these days. So it would be great to listen from Dr. Subankar sir. Yeah. Thank you very much, everyone, for joining today. We'll upload this on YouTube very soon. And please be in touch. Thank you. Bye.